Welcome back, warriors. So in this video we are going to review autoimmune pancreatitis. Now we have two types of autoimmune pancreatitis. We have type 1 and type 2. Type 1 is related to IgG4 antibodies, while type 2 is not. So the pathophysiology is in type 1, it includes a triad of three components: plasma cell involvement, lymphocytes, and fibrosis. And the plasmacytes are important to produce the IgG4. It's also associated with other autoimmune disorders like primary sclerosing cholangitis, thyroid disorders, and Sjogren's disease. While in type 2, it's unrelated to IgG4, and it's also associated with inflammatory bowel disease, Crohn's disease, and ulcerative colitis. Remember, in type 1, sometimes they might mention that the appearance of the pancreas is like a sausage shaped. The presentation on both of them is acute pancreatitis, and the diagnosis, always make sure if there is any kind of describing a mass or something on imaging to rule out cancer, so you need to do a biopsy. And for the treatment, because it's autoimmune, you give steroids. If we have a relapse, also you give steroids. Now let's review the complications of acute pancreatitis. We have multiple complications. First, we have the lung involvement, ARDS, acute respiratory distress syndrome. Also, we have the third spacing, ascites and pleural effusions, and the amylase level would appear high. And also we have the cyst, the pseudocyst, remember this. And also recurrent acute pancreatitis might lead to chronic pancreatitis. So chronic pancreatitis as a complication. We have also the splenic vein thrombosis. We have explained this topic on the GI tract bleeding video. Now, for pseudocyst, it's a pseudocyst, which means it doesn't have a real membrane. It appears after 2 to 4 weeks of acute pancreatitis. Now, regarding the symptoms, it might be asymptomatic or symptomatic. The symptoms include pain or complications, infection, fistula formation, and rupture. If it's asymptomatic, we don't treat it. We just monitor. It will resolve spontaneously. If we have any symptoms, then we need to drain this pseudocyst. And remember, in case of infection, it's harder to differentiate it from pancreatic abscess. So we drain it, we culture the drain, and we give antibiotics. And always remember, if it's asymptomatic, you don't treat it, regardless of the size, regardless of the location. Now let's move to chronic pancreatitis. In chronic pancreatitis, the main symptom is the pain. Most of the patients will complain of pain. It is secondary to the recurrent attacks on the pancreatitis. So multiple episodes of acute pancreatitis will lead to chronic pancreatitis. The most common risk factor is alcoholism. Smoking also is a risk factor. We have autoimmune pancreatitis as a risk factor. And of course, cystic fibrosis is a risk factor. The loss of the exocrine function of the pancreas will lead to malabsorption. And this will lead to weight loss. And fat malabsorption, this will lead to vitamin K, E, and D and A deficiencies. And for the loss of the endocrine function and the lack of production of insulin, this will lead to diabetes mellitus. So regarding the presentation, remember all these stuff. For the diagnosis, amylase and lipase won't help you a lot. So with the recurrence of the pancreatitis, their levels will start to decrease until they appear normal. So with time, they might be high, they might be normal. So they won't change anything in the diagnosis process. The cornerstone of diagnosis of chronic pancreatitis is imaging. You need to do CT scan abdominal with pancreas protocol. It will show calcification. Sometimes in exams they might put an X-ray showing microcalcification or macrocalcification. This will lead you to know that we have chronic pancreatitis with typical image, clinical image. So in case we have typical image but the CT scan is negative, then we do MRCP or MRI or endoscopic ultrasound to confirm the diagnosis. Don't be fooled and never answer ERCP to diagnose chronic pancreatitis. It's the wrong answer. You don't do ARCP, you do MRCP, MRI, EUS. For the treatment, you have to replace the enzymes and to replete the vitamins in case of any deficiencies. Then you have to control the pain. And remember, you should give insulin in case of diabetes mellitus. And for the medication of pain, we give NSAID, acetaminophen, TCH tricyclic antidepressant, SSRIs, but you should avoid narcotics in chronic pancreatitis. Never use narcotics because the patient will he will develop tolerance and dependence on them. This is first. Second, they will affect the sphincter of Oddi's sphincter, so never use them. However, in acute pancreatitis, you can use morphine, but avoid mebridine in case you saw it as an answer. In acute, you can use narcotics. In chronic, don't use narcotics. And remember, guys, you always remember cystic fibrosis. Whenever you see a patient, he has typical clinical image of chronic pancreatitis, malabsorption, weight loss, to rule out cystic fibrosis. And now question, if we have a pseudocyst size 7 centimeters, what to do next? You ask about the symptoms. If it's symptomatic, you treat it. Not symptomatic, you let it go on its own. Thank you guys for watching the video, and thank you for all the support to the channel. I know it's a small channel. We're using very basic tools to do these videos. We will continue to produce them until we have better quality videos. Thank you for subscription and all the support. Good luck on your preparations.